Hi everyone and welcome to our module on Pharmacodynamics II. In this module, we're focusing on the remaining two components of Pharmacodynamics II. In the previous module, we had talked about the component of drug action. For this particular module, we're talking about the component of drug effect and the component of dose-response relationship. As a form of reminder, pharmacodynamics describes what the effect of the drug on the body. Simply put, it is defined as what the drug does to the body, and this is in contrast to what we have for pharmacokinetics, which talks about what the body does to the drug. The component of pharmacodynamics includes the component of drug action. We talked about that in the previous module, drug effects, and dose response relationship, which we're going to be talking about in this module. So this picture captures in a nutshell the concept of pharmacodynamics with respect to drug effect. So what do I mean? So if you look at the top left corner of the screen, you could see the drug Viagra. Viagra is also known as the drug sildenafil. Viagra is typically prescribed to patients that are suffering from erectile dysfunction. So when using this drug, the effect that we want to see as a result of the use of the drug would be the effect of penile erection, and that's the effect that is depicted in the image to the right. Drug effect in terms of definition refers to the physiological change brought about by a drug. And these are visible changes that we could see as a result of using a particular drug. The type of physiological change that we see after using a drug are divided into two types. We could have a therapeutic effect or an adverse effect. Therapeutic effect would be the effect that we want to see when using a drug. It's the reason why we use a particular drug. So if I'm taking paracetamol as a result, it's most likely that I want the paracetamol to relieve my pain or relieve the headache I'm having. And that will be the therapeutic effect of the paracetamol. Whereas the adverse effect would be an unwanted effect that we are not really keen on seeing, but it's something that comes together with the drug. As I said before, therapeutic effect would be one of the physiological changes that we could see when using a drug. Therapeutic effect is also called a beneficial effect, and as the name implies, it's there for therapeutic purpose while we're using a particular drug. It refers to the physiological change that is expected and desired. These words are very key. It's expected and it's desired is what we want to see happen when using a drug. And it typically occurs at normal therapeutic dose. Any dose that is below this will lead to no effect whatsoever, but any dose above the therapeutic dose might lead to the adverse effect, which we'll talk about next. Examples of a drug and its drug effect that is therapeutic would be paracetamol and headache relief. And this image captures the idea of therapeutic effects. You could see on the left hand corner of the screen is a woman with headaches, and using paracetamol on the right hand side of the screen would lead to the beneficial effect or therapeutic effect of headache relief. The second type of drug effect is the adverse effect. Adverse effect is also called adverse reaction. So in case you see adverse reaction, that could be used in place of adverse effect. It could be used interchangeably. Adverse effect simply refers to physiological changes that are undesired. The keyword here is undesired. And adverse effects may or may not be expected. So you could expect an adverse effect just based on the pharmacology of the drug, or it could be an adverse effect that is not expected at all. It also may or may not occur at normal therapeutic dose. So sometimes, or typically, when you increase the dose of a particular drug, you will likely see adverse effects. But sometimes you could have a scenario where even the normal dose of the drug will also produce the adverse effect. Examples of drugs and the type of adverse effect they produce would be aspirin and bleeding. So aspirin typically will produce an undesired effect of bleeding and an expected effect of bleeding. So bleeding for aspirin tends to be expected and undesired. Whereas another side effect of aspirin or adverse effect of aspirin would be what we call Reye syndrome. Reye syndrome is an adverse effect of aspirin that is undesired but unexpected. So you could see that aspirin could have two different types of adverse effects, one that is undesired and expected, another that is undesired and unexpected. We have different subtypes of adverse effects. So the subtypes of adverse effects includes type A to F adverse effect. Type A typically is referred to as the augmented type of adverse effect. Type B is the bizarre effect. Type C tends to be chronic or continuous effect. Type D is the delayed effect. Type E is the end of use, and type F is the failure. And each of these effects, we'll talk about them in the next couple of slides. Starting with the type A adverse drug effect or adverse drug reaction. This is described as being an augmentation, or it's called referred to as augmentation or augmented effect. So this effect typically is dose dependent. So if we increase the dose of a drug, we might most likely see type A effects just due to the fact that we're increasing the dose of the drug. So drugs that are given above the normal therapeutic dose could produce the type A adverse effect. And the effect or that we refer to this effect are typically predictable or expected. So type A is an example of an undesired effect that is predictable and is dependent on dose. Type A is the commonest form of drug adverse effect that we see, and it is responsible for at least two-thirds of the adverse drug reactions in the world. And very important to note, type A effects are due to the pharmacology of the drug. They are due to the pharmacodynamics of the drug. Hence the reason why we're talking about them. Yeah. So we have three major mechanisms by which the type A adverse drug reactions can manifest. They could either manifest as a side effect, a secondary effect, or a toxic effect. I'll talk about each of them in the next couple of slides with examples. But examples of generally type A adverse drug reactions include the use of phenytoin and the adverse effect of gingival hyperplasia, propranolol leading to heart block, and anticholinergic agent leading to dry mouth. Why these examples are classified as types of type A adverse drug reaction is because these are expected effects, and aside the fact that they are expected effects that we see in the drug, they are also based on the dose that we give and also based on the pharmacodynamics of the drug. So pharmacodynamics of phenytoin will allow it to lead to gingival hyperplasia. The pharmacodynamics of propranolol being a drug that tends to block the heart, would allow it to lead to the side effect of heart block. The pharmacodynamics of anticholinergic agent could also lead to dry mouth just based on the fact that it tends to reduce secretion in the salivary glands. So the mechanisms of type A drug reaction, the side effect, toxic effect, and secondary effects could be explained using these pictures. Starting with the side effect. Side effect typically are referred to as an expected unintended effect of a drug occurring at a normal therapeutic dose and related to the pharmacological properties of the drug. So a typical example of a side effect would be minoxidil. Minoxidil at normal dose could lead to an expected effect of hypertrichosis. Hypertrichosis is simply refers to excessive hair growth. And this is one of the reasons why, as males, some males typically use minoxidil as a drug in growing their beard. So if you want to grow your beard, just get a minoxidil um, treatment or topical agent and apply it to your skin. What happens is that minoxidil at normal dose, at normal therapeutic dose, would lead to excessive hair growth, and as a result, you can even use it for your benefits. So you could see that some side effects could be beneficial because the side effects they occur at normal therapeutic dose and they are usually expected and sometimes they can be desired, but typically they are usually undesired. In case of minoxidil and hypertrichosis, it could be desired because that will be the reason why you're using it. The image on the bottom screen shows the image of what we call a toxic effect. Toxic effect is distinct from side effects. Toxic effects are usually just exaggerated forms of side effects. So it's just the same thing as side effect, but it's exaggerated. And usually result when we increase the dose of a particular drug. That they result from overdose or prolonged use of a drug. So when we are using a drug like heparin or warfarin, the drug typically is a drug that tends to act on the clotting mechanism and block the clotting system. So if the clotting system is blocked by this drug, and that's the normal mechanism of the drug, what we're expected to see is that we're expected to see bleeding whenever there's a small cut on the wrist, as we can see in this particular patient. So toxic effects are similar to side effects. It's just that the difference is that toxic effect involves more of an increased dose. Side effect, on the other hand, occurs at a normal therapeutic dose, and that's the difference between two of them. The last mechanism of type A adverse drug reaction is the secondary effect. Secondary effect refers to an indirect effect or consequence of the primary action of a drug. And this is typically explained using the example of pseudomembranous colitis, which is a condition that occurs when we use an antibiotic. So imagine using an antibiotic. The normal function or primary function of the antibiotic is to clear infection, to destroy microorganisms. But that particular drug antibiotic can overdo in terms of what you sent it to do after using it. And what could happen is that the antibiotic could end up clearing a lot of the normal flora present within the site of use. So in the case of pseudomembranous colitis, we are taking a drug like clindamycin or cephalosporin or tetracycline. And this drug, because of how strong it is as an antibiotic, will want to um, clear the particular microbe we want it to clear alongside clearing normal flora. The normal flora that is present in the GIT is there to actually keep other bacteria in check, other bacteria like Clostridium difficile. So if we use a drug that clears the normal flora alongside the particular organism we want to clear, other organisms like the Clostridium difficile could start to be growing, start to be propagated or proliferating, and as a result, those other organisms that have been given space to grow would start to cause problem within the GIT, and that's practically what we see in pseudomembranous colitis. As you can see, the pink organism here that are killed are as a result of the use of the drug, the antibiotics. The antibiotics is doing its function normally, but the function that it's doing has already led to a different thing because we now have the Clostridium difficile normal flora being propagated as a result, and then they're leading to damage of the GIT. And that's what we see in this particular image. You can see the GIT using a colonoscopy, and the colonoscopy, you can see how the GIT has been damaged as a result of pseudomembranous colitis. IB adverse drug reaction is described as a bizarre type of reaction, and this is a reaction that is typically opposing uh, type A adverse drug reaction in the sense that it is not dose dependent. So it can occur at any dose, high dose, low dose, or non-therapeutic dose. It could occur at any dose. And the type of adverse effects we see with type B tend to be unpredictable. So remember that type A tends to be dose dependent and predictable. Type B tends to be non-dose dependent and unpredictable, unexpected. And type B typically is not related to the pharmacology of the drug, so it has nothing to do with pharmacodynamics of the drug. The mechanism of type B reaction tends to be twofold. We have allergies being one, and then idiosyncrasies being another. Examples of drugs that and adverse reactions that are classified under type B. Number one, we could have anaphylactic reaction due to use of penicillin. We could have methyl leading to hemolytic anemia. We could have prokinamide leading to drug-induced lupus. We could have poison ivy leading to contact dermatitis. And these are all examples that are typically under the using the mechanism of allergies, which I'll talk about very soon. Talking about the mechanism of type B adverse drug reaction, allergies being the first. Allergies are referred to as immunologically mediated allergic reaction or response occurring when a sensitized individual has been re-exposed to the same drug. And this type of reaction are not explained by the pharmacology of the drug. This is a very important point to note. And this is the reason why allergies are classified under the type B adverse drug reaction. A very common example of an allergic reaction due to a drug, which is type B adverse drug reaction, is the use of sulfonamides like septrin and the side effect of what we call Steven-Johnson syndrome. So the use of septrin, although we don't commonly see it's very rare, could lead to a particular life-threatening adverse drug reaction that we call Steven-Johnson syndrome. That's what this particular man is suffering from. In this reaction, the skin will be peeling off, and the man will be feeling as if his entire body is burning as a result. And the man could as well go into a life-threatening situation or condition as a result of this adverse reaction. This adverse reaction is rare, it's not really expected, and it's not necessarily based on dose. So it can happen to anyone at any time, regardless of whether you're giving a therapeutic dose or you're giving a very low dose or you're giving a very high dose. It does not really matter. The dose is not really a problem. Neither is the fact that it is unexpected. It's not really an expected thing. It's not something you can predict. It is unpredictable, unexpected, and not dose dependent. Another mechanism of type B adverse drug reaction will be what they call idiosyncrasies. And idiosyncrasies are genetically determined abnormal reactivity to a drug. And this is just by virtue of the fact that based on our genetic makeup, we could react to drugs separately. And usually, we can have different ways in which we react to drugs. Some people can have a hypoactive reaction, some could have hyperactive reaction to a drug. And this is by virtue of the genetics. The genetics is what tends to be the key word for idiosyncrasies. Example would be drug like chloramphenicol lead aplastic anemias in some patients. Most patients could have aplastic anemia just based on their genetic makeup. And this is just by virtue of the fact that the genes might not be able to make enough enzymes to break the drug chloramphenicol down very well in some people, whereas in other people, their genes are making enough enzyme that will break up the drug. So those people that have reduced amount of enzymes breaking to break chloramphenicol due to their genetic makeup would have issues with chloramphenicol in terms of the adverse effect of chloramphenicol. And in this case, the type of adverse effect that could result would be what we call an aplastic anemia. The third type of drug effects, under the adverse drug effect type C, adverse drug effect. Type C is referred to as a chronic type of effect or continuous type of effect. This is dose dependent. Typically, is what we call a dose accumulation effect. So it's due to excessive dose or an accumulated dose for a long amount of time. And it is also time related. I think the key thing to note about the type C reaction is the fact that it is time related. It occurs when we are giving a particular drug for using a particular drug for a long amount of time. It occurs during prolonged treatment of a particular condition using the same drug. The mechanism of type C typically is a toxic effect. Remember, we talked about toxic effect as well for type A, and that's why type A and type C are both dose dependent. For the toxic effect, remember, the toxic effect is a type of side effect, is a form of side effect that is just exaggerated, that is due to overdose or prolonged use, and that's why it is classified under type C. Typical examples of a type C reaction would be use of phenacetin and the adverse effect of interstitial nephritis. So if you're using phenacetin for a longer time, the side effect of interstitial nephritis could be one of the things you'd see. The use of anti-malarial agents. So as we'll talk about, could also lead to a particular adverse effect called ocular toxicity. Oral steroids could lead to osteoporosis. So these drugs, if you are using them within a short amount of time, they might not lead to the type C adverse effect that we are seeing. But with continuous use or with an accumulated amount of dose, these particular side effects could occur. So this is a picture showing us hydroxychloroquine. The use of hydroxychloroquine for a long amount of time or with an increased dose could lead to the adverse effect, the type C adverse effect of ocular toxicity. And it's important to note that this is time related. So just using hydroxychloroquine once or twice would not lead to problems with the eye, but with an extended period of time, it could eventually start seeing symptoms of problems with the eye. For the type D adverse drug reaction, this is described as being a delayed type of reaction. The type D adverse drug reaction is dose independent and not time related. This is completely different from what we talked about in type C. Type C typically is dose dependent or due to dose accumulation and time related. The reason why we say type D is not time related is because this type of reaction tend to occur after the treatment has occurred already. So imagine we use the drugs some months or some years back, and then we're seeing the side effect of the drug after 2 3 years. So it's not really time related in the sense that it does not really depend on time. It occurs after years after or months after treatment has already occurred. The three major mechanisms of type D adverse drug reaction are the mechanism of teratogenicity, the mechanism of carcinogenicity, and the mechanism of mutagenicity. I'll talk about this in the next slide. A typical example of a type D adverse drug reaction is the use of thalidomide and the side effect of limb hypoplasia. Usually, this occurs when a pregnant woman is using this drug, and the side effect is not going to occur when a pregnant woman, rather, it's going to be occurring on the child. And the child born would be having the side effect or the adverse effect of limb hypoplasia. One of the mechanisms of type D adverse drug reaction is teratogenicity. Teratogenicity is the capacity of an administered drug to cause fetal abnormality in a pregnant woman. So we have drugs that are referred to or regarded as safe or slightly safe or contraindicated completely in pregnant women. And drugs that are contraindicated or not really safe are drugs that are teratogenic. What happens is that once a pregnant woman is using these drugs, the drugs might not affect the pregnant woman at the time of use, but that drug, due to the delayed effect or delayed use, would eventually affect the unborn child, and the child will come out with different anomalies. So the chart below shows us the different types of drugs and the particular category we tend to give in terms of whether they are drugs that can be categorized as teratogenic agents or non-teratogenic agents. So class A or category A drugs are usually safe drugs. They have no risk in pregnancy and we can use them. So drugs like folic acid, we even prefer women to use folic acid during pregnancy throughout. Thyroid hormone as well could also be effective during and safe during pregnancy. Type B drugs are drugs that have no harm to humans, although they could have harm to animals. So drugs like erythromycin and penicillin are usually safe in humans, pregnant women specifically. For category C, these are drugs that are They have risks, but the risks have not been cannot be ruled out yet. So we just prefer prescribe them, but we always monitor them just in case. So drugs like ACE inhibitors and ifedipine. Type D drugs are drugs that have positive evidence of risk there, but sometimes when we are left with only one option, we could give these drugs, but just ensure we are monitoring the effect of the drugs. So we prefer not to give the drugs if there are alternatives, but if there's no alternative, we could just give the drugs and monitor their use. So they are positive evidence of risk. So drugs like aspirin, glyburide, and diazepam. Then we have the drugs that are totally contraindicated in pregnancy. So drugs contraindicated in pregnancy are drugs that are categorized as category X. And remember these drugs like warfarin, lovastatin, isotretinoin, and oral contraceptives. Warfarin is used in treating different clotting disorders. Isotretinoin is typically used in treating acne, and then oral contraceptive could be used in preventing pregnancy. So each of these drugs are completely contraindicated in pregnancy. One example of a drug that I didn't mention on this list is thalidomide. I already talked about thalidomide when stating the examples of type D adverse drug reaction. I'll show you a picture of what thalidomide could do in a pregnant woman. So it's the picture of thalidomide. Thalidomide used in pregnancy, or typically is used when a patient is having problems with vomiting as a pregnant woman. And we discovered that though the woman would use the drug to cure vomiting or treat vomiting at once, but that drug, due to its delayed effect, would have effect on the child eventually. And one of the effects is what we call limb hypoplasia. As you can see that after this woman has given birth, the particular child that was born tends to have a very reduced an abnormal form of limb, upper limb and lower limb. To quickly note, the other mechanisms of type D adverse drug reaction, aside teratogenicity, includes carcinogenicity. Carcinogenicity is the capacity of a drug to cause cancer in a patient. So, for example, anti-cancer drugs could lead to cancer. So, if you're giving an anti-cancer agent, you should also be aware that this anti-cancer agent could also even cause cancer. And aside carcinogenicity, we also have what we call mutagenicity. Mutagenicity is the capacity of a drug to cause genetic defect in a patient. And a typical example is the drugs or chemicals like radioisotopes. Giving radioisotopes to a patient that maybe has a tumor or a cancer or a particular thyroid problem, that radioisotope by itself could also damage genetic makeup of the patient and could lead to genetic defect or mutation. That's why it's called the mutagenic agent. And all this, the mutagenicity, carcinogenicity, and teratogenicity are all examples or mechanisms of type D adverse drug reaction. Type E adverse drug reaction is described as end of use. This is not dose related. It occurs when you stop using the drug appropriately. So there are some drugs that when prescribed a particular dose, we have to maintain that dose. If we are going to stop using that drug, there's a particular way we have to stop it. We have to stop it in different steps and not abruptly like that. But once you end the use of the drug abruptly, the side effects you have as a result is typically what we see or and what we call type E adverse drug reaction. So the mechanism behind this is what we call drug dependency or drug withdrawal. And drug dependency just talks about the use of a drug that produces a state in which continuous use of the drug is necessary to maintain normal physiological well-being. So drugs like benzodiazepine, for example, once you start using those drugs and you're using it for a long amount of time, your body gets adapted to that drug and your body would need to be seeing that drug continuously. Stopping the drug abruptly will lead to your body being dysfunctional because the body will not be able to survive without it. The body becomes dependent on the drug. So withdrawal of the drug would lead to symptoms or what we call withdrawal symptoms. So a very common example is withdrawal symptoms we see in benzodiazepine or even withdrawal symptoms we see in alcohol use. The last type of drug effect is what we call the type F adverse drug effect, and this is described as being the failure of the drug. This is not dose related and it occurs as a result of therapeutic failure of the drug. If a drug was given for a particular reason and we don't see the therapeutic effect of the drug, we could see an adverse effect that is just due to the failure of the drug. Typical example is when we give an antibiotic or antimicrobial agent and the bacteria or the microbe is resistant to the drug. The resistance of the microbe will lead to even a greater infection as a result of the drug used. So, and this is the typical example of a type F adverse drug reaction. Before we jump into the next half of this particular module, it's important to note the difference between an adverse drug event and an adverse drug effect. Adverse drug effect is also called adverse drug reaction. So in case you say adverse drug reaction, it means the same thing. And that's what we just talked about today. So adverse drug effect is described as an untold or untoward medical occurrence that may be present during treatments with a medicine. And it's usually based on the um, relationship between usually a causal relationship suspected that established between both the drug and the effect. And this is just all those effects we talked about from type A to type F. These are the types of effect that we refer to as adverse drug effect. It is due to the use of the drug. It's a side effect or adverse effect that we see as a result of using the drug. So there's a relationship between the adverse effects and the drug that's being used. For adverse drug events, this is a different thing entirely. It's an untold medical occurrence that may be present during treatment with a medicine, but there's no necessarily a causal relationship between the treatment and the effect. So in this case, the effect you are seeing is not due to the treatment, it's due to something else. And this is usually typically seen when there are errors in treatment, maybe a prescribing error. Instead of giving a particular drug, we give a different drug entirely, and we are seeing side effect of the different drug that was prescribed. In that case, that's not the drug effect. That was going to be a drug event, adverse drug event, in the sense that instead of giving the prescribed actually prescribed drug, we're giving it separate drug, and that's leading to problems. Another type of error we could see that would be regarded as an adverse drug event is a medication error, in the sense that we might be giving a particular prescribing a particular drug, or prescribing the actual drug, but the particular dose we're meant to give for this drug was the area where we had the error in. Maybe we're meant to give 5 milligram of a particular drug, we're giving 500 milligram. And as a result, though there's adverse effects in this case, but the adverse effect is not due to the drug, it's just due to medical error, and it's due to medication error specifically. So it's a matter to note these two times because they could use it interchangeably to confuse you. Event is different from effect. Effect is the same thing as reaction. So in case you see adverse drug reaction, it's the same thing, but in case you see adverse drug event, it's a completely different thing. Let's talk about dose response relationship. Now, typically, doses are a major factor determining the drug response. The dose of a drug is directly proportional to the drug response, and this is simply explained by, for example, if we are using paracetamol, let's say we have a headache now and we're taking paracetamol, we take one tablet of paracetamol, that's a particular dose of paracetamol, probably let's say 500 milligram of paracetamol. As individuals that are adults, that particular dose might not be effective, so we will not see any response. But in case times when we increase that particular dose to, let's say, 2 tablets, we can start seeing symptoms. We can start seeing pain relief as a result. If we step it up the dose of paracetamol to 3 tablets, the pain might eventually disappear. So what this means is that with every increase in dose, there's an increase in the drug response as a result. And even there's also an increase in the type of effect that we see. Remember that the particular dose that we give might determine whether the drug would have a drug effect or no effect at all. As we increase the dose, you could have a therapeutic effect. As you increase the dose further beyond the therapeutic dose, you could have an adverse effect. So with every increase in dose, there's an increase in the response. The response could either be a lethal response or an effective response. The relationship between the dose and the drug response has been calculated and measured using a particular curve or concept we call log dose response curve or LDR curve. And we'll talk about this in the next couple of slides. Here's a picture showing us the LDR curve. The LDR curve is a measure of the relationship between the response of the drug and the dose or concentration of the drug. And what you notice is that as we start to give a drug, starting from this zero, um, the zero concentration of the drug, we have no response. But as we increase to a particular level, we start to see response. The point where we start to see response is typically referred to as the minimum or threshold dose. As we keep on increasing the dose of that particular drug, the response will also increase. We can see that there's a directly proportional relationship between the drug concentration and the response that we see. And um, once we get to a particular point, when we get to a particular dose, further increase in that particular drug will lead to no other um, response. At this point, we see that the response of the drug has gotten to its maximal effect. We have maximal response or effect as a result. The parameters you need to remember in terms of the log dose response curve are the parameters that are shown on the screen. So we have the maximum effect, also called the Emax. All right, we have the slope. Slope is used in performing statistical analysis. We have what we call the potency of the drug or the EC50. We'll talk about this soon. We have the minimal dose or the threshold dose. So each of these parameters are parameters that we can get when we perform or plot the log dose response curve to check the relationship between the dose of a drug and drug response that we see. What are the features of the LDR curve? LDR curve, first of all, is sigmoid shaped, and there's another type of curve that is hyperbolic in shape. This curve is referred to as the dose response curve. So if we are plotting a dose response curve, typically what we have is what we call hyperbolic curve or hyperbolic shaped curve. But once that particular dose is converted to the logarithm of the dose, when we're having a log dose response curve, the shape of the log dose response curve is sigmoid in shape. So please don't make mistakes in confusing both of them. The LDR curve involves the plotting of the log dose on the x-axis. X-axis is also called the abscissa, and the response is plotted on the y-axis. Y-axis is also called ordinate. And in a log dose response curve, there usually would be a point of maximum effect, what we call the Emax. So the log dose response curve would always possess an Emax. Aside that, the log dose response curve would have a slope. The slope usually represents 20 to 80% of the curve. It's usually a straight line where statistical analysis could be performed. So remember that aside the Emax, which is one of the parameters we see in a log dose response curve, we could also see a slope. That slope represents a straight line that is 20 to 80% for statistical analysis. Another thing to note about the features of the log dose response curve is that drugs with similar mechanism of action usually have very parallel curves. And then finally, once we get to the Emax, the maximum effect, an increase in the concentration of the drug, an increase in the dose of the drug will not produce any further increase in response. And this is noted in that particular image as the topmost part of the curve. What are the types of dose response experiment that we can perform? So we have two major types of dose response experiments if we want to check the relationship between the dose of a drug and the response. And these experiments include the graded response and the quantile response. I'll explain what these two concepts mean in the next slide. So imagine we want to check the relationship between a drug dose and then the response of the drug. There are two ways we can carry out that. We can either use a graded response. Graded response are usually used and carried out when the particular drug we're trying to study is a drug that produces a response that can be graded, that can be measured. So take for example, we want to carry out a graded response experiment on an antihypertensive agent. Antihypertensive agent will be a drug that the response or the effect of the drug is the lowering of blood pressure. So blood pressure, we can measure it. And because we can measure the blood pressure, we can measure the different effect of the blood pressure that we see when we give different doses of the drug. So let's say we give 50 milligram of the drug, and that 50 milligram will lead to the blood pressure being reduced from 120 to 100 over 70. And let's say we increase the dose to 200 milligram. 200 milligram will lead to the drug to the blood pressure being dropped to, let's say, 90 over 60. So because we can measure the response or measure the effect of the drug, we say that the drug experiment is usually graded. It's a graded response. So graded response, there are a few things to note about the graded response experiments. First of all, graded response experiments are carried out on just one subject. We're not going to be carrying out this experiment on multiple individuals, just one subject. Aside that, we are looking at the relationship between the dose and the intensity of the effect. The intensity of the effect is what we're checking out for. So how much effect, because the dose is proportional to the effect, how much of the effect would we see if we increase the dose? And that's what we're looking out for. And the parameters that we arrive at when performing a graded response experiment are parameters of EC50 or potency, parameters of Emax, and then the threshold dose. We'll talk about this in the next slide. This is an image that shows us the an example of the graded response experiment. This is a graded response curve, and you could see some of the parameters that would reduce from the graded experiment. You could see the Emax here. Emax is the highest response that we could get, and we can see EC50. We'll talk about that next. So the first parameter we could deduce from a graded response experiment is what we call potency or EC50. EC50 is also called effective concentration 50. Potency or EC50 of a drug is measured as the dose that is required to cause 50% of the response. Please, the keyword is 50% of the response. What does this mean? So it means that the dose that would cause 50% of a particular drug effect, that dose is referred to as the EC50. And because we could have different drugs performing similar effects, we could compare drugs based on their potency or EC50. So the general rule is that the lower the potency or the lower the EC50, the more potent the drug is. So a drug that requires a small dose to cause 50% of response is very potent. A drug that requires a very large dose to cause 50% of the response is not really potent. And we can compare potency in that sense. Because drugs can be more potent than others does not mean that a drug is superior to another. So more potent drugs doesn't necessarily mean a more superior drug. In fact, potency is not really clearly clinically relevant. What is more clinically relevant is the Emax or the efficacy. Efficacy is the maximum response that we can see for a drug. So drugs could be very potent, could have a very low EC50 and be very potent, but they could have a very small Emax or efficacy. The Emax, on the other hand, is the second parameter we tend to get from the graded response. Emax is the maximum response that we could get. So Emax talks about the response or the effect. The potency talks about the dose, and it's the maximum response that we could achieve as a result of using a drug. The Emax is more clinically relevant than potency, and that is very important for you to note. Here's a case study for us to try out that explains the concept of a graded response. An experiment was conducted to determine the drug dose response relationship of the drug tramadol. Multiple doses of tramadol was administered to a lab rat, and the rat was observed for changes in effect corresponding to the dose. So, few things to note about this particular experiment. Number one, we're carrying out a graded experiment, and how we know it's a graded experiment is because we're using just a single lab animal. A single lab rat, as shown in this picture, is what we're using. So single subject is what we are going to be using to carry out the experiment. Secondly, we are giving multiple doses to this single subject. We are going to be increasing the dose and observing for changes as we increase the dose. The result or outcome of this experiment is shown in the next slide. So this is the outcome of the experiment we carried out in the case study in the previous slide. As you can see, with every increase in dose, there's a change in response. So let's say we started with just 10 milligram of the drug at this point. At 10 milligram of the drug, there was no response at all. There was no effect. As you increase the dose, let's say you increased it to 20 milligram. 20 milligram led to the particular lab rat feeling giddy. So giddy was the first response. Let's say the response is equal to 10%. All right. Then we increase the dose further to 30 milligram. 30 milligram led to the lab rat sleeping. So let's say sleeping in this case was a 30% response. And then as we kept on increasing the dose, we increased the dose further to about 50 milligram, or let's say 40 milligram. And 40 milligram led to this lab rat going into deep sleep. Deep sleep in this case is regarded as 50% of the response. As we further increase the dose, we increase it to 50 milligram. 50 milligram led to the lab rat being unconscious. Unconsciousness was a 70% response for the lab rat. And as we further increased it, we increased it to 60 milligram. That led to the lab rat going into labor breathing. This was 90% of response. And then finally, as we increased it further to like 70 milligram, that lab rat ended up dying. And death in this case is referred to as the maximum response. As we further increase the drug, let's say we increase it to 80 milligram or 90 milligram, that led to no change at all. Remember that once we get to the Emax in this case being death, 100% of response, further increase in the dose will not lead to any further increase in response. So Emax in this case will be death, whereas the potency or the EC50 in this particular experiment, we can deduce the potency or EC50 in this experiment would most likely be the 40 milligram, because at 50% of response, which is deep sleep, 40 milligram of the drug led to this particular response. So the dose that led to 50% of the response is referred to as the EC50 or the potency of the drug. Another concept of or what we call therapeutic dose or minimum effective dose is also seen. Minimum effective dose is a dose that is required to cause an effect. So any dose below 10 milligram would be referred to as outside of the window of therapeutic response. From 10 milligram and above, we start to see effects from there. Anything lower than 10 milligram will not lead to any response at all. So 10 milligram, from 10 milligram and above, we start to see response. So 10 milligram is going to be referred to as the therapeutic dose or the minimum effective dose. Second type of response we have is what we call a quantum response. Quantum response is a type of experiment that we carry out on drugs that has effects that we cannot grade, that we cannot measure. So take for example a drug like paracetamol. Paracetamol is a drug that we would want to carry out a quantum experiment on, because paracetamol, the type of effect we see is a yes or no effect. It's an all or none effect. Paracetamol could either cure headache or not cure headache. So it's not as if we can grade the amount or the intensity of headache it's curing. Yes, we can only say yes or no to the effect of this drug. So drugs that have a yes or no or all or none effect are drugs that are measured using a quantile response. It's important to know that compared to the graded response, quantile response, we tend to measure it in a population, not a single subject. So contrast to what we have for graded response, quantile response is measured using a population. Aside that, the dose is usually related to the frequency of the effect, not the intensity. So for graded response, we are relating the dose to the intensity of the effect. For the quantile response, we're relating the dose to the frequency of the effect. The parameters we get from a quantile response differs from what we get from a graded response. For a quantile response, we get three major parameters. So the parameters include ED50, LD50, and the therapeutic index, which is what we can see here. You can see the ED50, you can see the LD50. Sometimes we talk about the TD50, but this is not something that they frequently talk about, especially in your class. We just focus largely on the ED50 and LD50. We'll talk about that in the next couple of slides. The ED50, also called the effective dose 50. This is different from the EC50. EC50 is a parameter we see for graded response, and it's called effective concentration 50. ED50 is called effective dose 50. ED50 refers to the dose required to produce response in 50% of population. Please always distinguish this from EC50. EC50 is the dose required to cause 50% of response. 80/50 is the dose required to cause response in 50% of population. Remember that for quantile experiments, we are going to be performing this experiment on a population, not a single individual. And as a result, the dose that would cause the effect we want to see in 50% of population is referred to as the 80/50. LD50 is the dose that is required to produce deaths in 50% of population. This is important to note. Death is what we're looking out for LD50. So death is the is the yardstick to measure E50. Once death occurs in 50% of population of a particular dose of the drug being given, that dose is the LD50. TD50 on the other hand, although it's not shown in the slide, is the toxic dose 50, is the dose required to cause toxic effect or adverse effect in 50% of population. We don't really talk about the TD50 so much. We prefer to talk largely about the LD50 and the ED50. The last parameter for quantile response is the therapeutic index. Therapeutic index is a measurement of drug safety. We calculate the therapeutic index using the formula LD50 over ED50. So once we get the LD50 and we get the ED50, we just divide them. And what we get after division of these two parameters is what we call the TI, or therapeutic index. Like I said, TI is the measure of safety of a drug. So drugs with a very low TI are considered as very toxic drugs, and drugs with a very high TI or low TS are considered as very safe drugs. So example, dioxin is an example of a drug with a very low TI, and because it's a very low TI, it's a very toxic drug. So we need to really monitor the levels of dioxin if we are being prescribed it. Then penicillin is an example of a drug with a very high TI. So penicillin are relatively very safe. What this tends to entail or mean is that because the TI is the measure of the LD50 compared to the ED50, if the TI is low or small, it means that we need just a small increase in the ED50 for lethality to occur. Remember, ED50 is the concentration or the dose of the drug required to cause effective response in 50% of population. If the distance between the ED50 and the LD50 is very small, meaning that the TI is very small, it means that just by increasing that drug by a very small amount could automatically lead to death in 50% of the population. Hence, the reason why a low TI is toxic. All right, very high TI would mean that the gap between the ED50 and the LD50 is very large. So we can keep on giving it increased dose of this particular drug from the ED50 and we will not see any lethality or toxicity. So drugs like penicillin have very high TI. Drugs like dioxin has very low TI. There are many other drugs with a very low TI you should know about. You probably learn about this more in your clinical pathology lectures, because we tend to monitor these drugs in the blood, and as a result, we learn it in clinical pathology. It's a case study that talks about the quantile experiment or quantile response. An experiment was conducted to determine the drug dose relationship of a new anti-cancer drug X. So anti-cancer drug would be an example of a drug that would fit into the criteria of a quantile response, because the type of effect we're looking out for the anti-cancer drug is a yes or no effect. Is an all or none effect. Is that this anti-cancer drug cures the cancer or does not cure the cancer? We cannot really grade the level at which it's curing the cancer. So different doses of drug X was administered to a population of 100 lab mice. This is important to note as compared to what we have for the For the graded experiment, we are giving this drug in to a population of lab rats, not lab mice, not a single lab mice. So we're giving it to multiple lab mice. The mice were divided up into 5 groups, 20 in each group, and the dose of drug X, drug X was administered to each group as follows. So we have group 1 getting 20 milligram, group 2 getting 40 milligram, group 3 getting 60 milligram, group 4 getting 80, and group 5 getting 100. So each of the groups have 20 mice, and each of those groups are given different doses of the drug. We're not increasing the dose of any of the drug in one group. So we just give 20 milligram to the drug and just look out for the effect. For one group, we give 40 milligram to the second group and just look out for the effect. We do the same thing for the third, for the fourth, and for the fifth. And this is what distinguishes the quantal experiment from the graded experiment. The outcome of the experiment is as follows. In group 2, we had 10 mice being cured of cancer. In group 4, we had 10 mice dying. Remember that for each of those groups, we had 20 mice in each group. If in group 2, 10 out of 20 mice were cured of cancer, it meant that we saw effective response in 10 out of 20 mice. We saw effective response in 50% of population. As a result, the dose that was given to the group 2 mice is going to be referred to as the ED50. So we say 40 milligram is the ED50 in this case because after giving 40 milligram to the group 2 mice, 10 out of 20 of those mice, which is 50% of population, were cured of cancer. We saw effects there. In group 4, 10 mice died. So the dose given in group 4 meant that that 80 milligram led to deaths in 50% of the population. If we had 20 mice in group 4 and 10 of 20 mice were dying as a result of the drug use, then the dose given in group 4, 80 milligram, is going to be referred to as the LD50, the lethal dose in 50% of the population. And then to calculate the therapeutic index would be the ratio between the LD50 and the ED50, which is 80 milligram divided by 40 milligram. And the therapeutic index of this drug will be 2 to 1. Typically, we use the benchmark of 2 as a measure of therapeutic index, but the higher the therapeutic index, the safer the drug is. So once the drug has a therapeutic index of 2:1 or greater than 2, that drug could be considered as being safe. It just means that we need to step up the dose times 2 before we see side effects or see lethality in 50% of the population. If we have a therapeutic index being 1 or less than 1, that drug could be considered as being very toxic. So the smaller the therapeutic index, the more toxic the drug could be. So in this case of this experiment, the anti-cancer drug could be considered as a safe drug because it's having a therapeutic index of 2, which is along or within the margin of safety to an extent. And that concludes our module on pharmacodynamics 2.